Alcoholism is an issue that can have significant ramifications for a person's life and society at large. The struggles that alcoholics have experienced and the stigma they have endured has led people, both the sufferers and the scientists, scrambling for answers, even today with all our psychological knowledge. So does taste aversion create behaviour change for alcoholics? Intuitively, it would seem that the answer to this question is straightforward. We have all had the experience of smells and tastes creating a sense of disgust and associated nausea. My adult sons can regale me with stories of their experiences where they can no longer ingest a particular beverage, for they have conditioned a nausea reaction to the mere sight and smell of this drink. Taste aversion as a form of classical conditioning is phylogenetically old and of significant survival value. Thereby, if we can rely on heuristics, we could wonder in this modern age at the validity of this research question. But there are inconsistent results, and the rest of this presentation will focus on one study that was created to further explore the reasons behind these less than robust findings. According to Howard and Co., the history of building a neural association between alcohol and an aversive experience dates back to the 1st century AD. But since the 18th century, pairing emetic therapy with alcohol has been a regular practice. Most commonly used emetic therapy today is disulfiram, or generically known as antabuse. The regular prescription of disulfiram by doctors in Denmark, despite limited and inconclusive evidence, led Ulrichsen and Co. to conduct a further study. According to Ulrichsen and Co., it was the lack of supervision in early research and the blinded design that may have led to no significant difference between the treatment and the control group when using emetic therapy for alcohol use behaviour change. Ulrichsen and Co.'s aim was to ascertain if disulfiram could prevent alcohol consumption in people with long-term alcohol use disorders. Ulrichsen and Co. hypothesised that supervised dosages of disulfiram would produce abstinence for the entirety of the treatment period and would increase the time before the first drink. Of the 497 male and female patients between 18 and 70 who were admitted to a Denmark hospital for withdrawal, 242 were found eligible, 158 refused to participate, and then a further 45 withdrew consent, leaving the study number to be 39. All participants were treated with phenobarbital to eradicate withdrawal symptoms in order to reduce confusion between treatment and regular withdrawal. Patients were randomised into either a supervised disulfiram treatment group or a control group. For a period of 6 months, participants attended outpatients twice a week, where they were breathalyzed, given 800 milligrams of disulfiram under the supervision of a nurse, and participated in 16 cognitive behavioural therapy group sessions. The main findings from this study were that the supervised administration of emetic therapy did not affect the treatment outcome. Remembering that abstinence for the duration of the treatment time till the first drink, the number of alcohol-free days were to be the key indicators of disulfiram's effectiveness. It is relevant to note that during the 26-week period, 5 from the disulfiram group and 7 from the control group were treated in the psychiatric emergency department following a relapse. Ulrichsen and Co. concluded that their findings had no effect could have been confounded by a type 2 error, as their selection process potentially reduced the representativeness of the entire population of alcoholics. A further factor that may have contributed to a null hypothesis is the psychiatric comorbidity amongst the participants. They identified that the motivation of the patients could produce different results with emetic therapy treatment. Ultimately, these findings suggest that given these constraints, using emetic therapy as a first line of treatment in outpatient programs lacks efficacy. Ulrichsen and Co. clearly identified that their study appeared to have both significant flaws in its design and patient cohort. A significant number of eligible patients refused participation because they wanted to be treated with disulfiram. This left researchers with a relatively low number to be representative of the efficacy of emetic therapy. So we have come to the conclusion of this presentation, and the original question, does TA produce behaviour change, still does not appear to have a straightforward answer. It is interesting to note that Ulrichsen and co. state that the main effect of disulfiram is psychological, as the unpleasant ethanol-disulfiram reaction can be a deterrent. This psychological effect may warrant more research. However, taste aversion does not appear to be generalised where alcohol is concerned. Treatment effectiveness appears to be exceedingly conditional and unsustainable by an individual as a singular treatment option for alcohol abuse. I would question the construct of behaviour change. The principles of classic conditioning indicate that a conditioned response increases with each pairing and can be generalised. The results of these findings suggest that emetic therapy must be consistently supervised and has not created taste aversion that is generalised over a 6-month period of regular pairing. I suggest that emetic therapy produces short-term behaviour modification rather than behaviour change. As such, and given the significant impacts mentioned at the beginning of this presentation, further research into the effectiveness of taste aversion treatment with patient self-efficacy would be warranted.